in charge of telemedicine in Ramchandra University. So we will just go ahead with the first speaker. Will talk Sujit John on telepsychiatry.
You just need to have really good video conferencing facilities available, but it means language is a major issue. The psychiatrist needs to be able to talk to the patient and be able to gauge the responses, look at the nuances, look at facial expressions. So all of this becomes important. So we restrict ourselves to Tamil Nadu so that we could do our consultations in Tamil, and if necessary we could do it in English, but we really weren't equipped to do it in other languages. So the way we started is we started off with fixed line clinics. Now from 2010, with some additional funds being made available, we have started in Pudukkottai district, and what we actually do is we run a mobile service. So we have a van which goes around. We have not been lucky enough to get VSAT connections, so we are restricted somewhat by the fact that we use 3G connections, wireless connections for video conferencing. So that limits the number of places that we can actually go, because it's not everywhere in the remote villages that you actually get a good enough wireless connection. So at present we have mobile clinics in 5 areas, which basically run from Monday to Saturday. So this is basically what a telemedicine network is. So we have basically been working in over 12 areas. Things that are in black, more or less we have stopped functioning in those areas, mainly because the district mental health program and the national mental health program is kicked in all those districts. So all the blue dots are no longer functioning. It's the red dots that we are currently providing services to. So how do we actually go about doing it? One of the things that we do is, one of our first steps is, wherever that we are going, one of our things that we look at is, this is an area which doesn't have too many psychiatrists. It is not covered under the district mental health program, so we have enough people there with mental illness who do not have a place to go. And the way we do is we network with the local NGO in those areas. And in Tamil Nadu, one good thing is we have a lot of self-help groups, women's self-help groups for microfinancing and things like that. So you get involved with these groups, you train these people on basic symptoms of mental illnesses. You're not looking at diagnostic criteria or specific categories of mental illness. You just tell them, these are, if you see somebody with, you give them a checklist of symptoms, then you send them to our clinic and we'll take care of them. And so as part of it, we have a lot of training programs in the villages that we conduct with these self-help groups and the volunteers of the local NGO. We also have street plays, we have skits, we have shows, which also creates awareness in these villages in terms of the services that we are providing, how it is telepsychiatry that works and stuff like that. Of course, what you can see on the lower half here is the bus that we have, that we use for mobile psychiatry. So we have a 50-inch television screen at the back. So we are also able to take that around and show awareness films and stuff like that. And what happens during clinic, one of the things that we have realized very clearly is telepsychiatry is not the ideal way of treating all types of mental illness. For example, there would be, it's good for serious mental disorders which you can do with, where you can prescribe medication and to a large extent sort out issues. But where you need to do a lot of other types of support group therapy, like let's say counseling or behavior modification or lifestyle change, this system doesn't work quite as well for those kind of therapies. So we have restricted ourselves to looking at patients with serious mental disorders where we can be more effective in our delivery of service. The other limitation also is the fact that with serious mental disorders, two-thirds of our patients are likely to be ill for life. Uh, some of them would have fluctuating course of illness, others are not going to recover. It's quite different. So it's not a one-point time of contact that you can look at patients, then come out of it and go to the next village. It means we have bound to have a 30-day cycle revisit at every point of time. So every patient that we see, at the minimum, we need to see them again for a follow-up for 30 days. So that also restricts our services in terms of how much we can expand and how much of a caseload that we can take. So these were some of the reasons why we decided that we would stick to serious mental disorders, where we can be more effective in our delivery of services and have better outcomes, and also the fact that we have to come back every 30 days to these places to see these patients again. So we have a process where which anybody who comes to the clinic is actually screened out. So we have a checklist which is administered basically by people that we have trained locally, and they would see if the person has got a serious issue. If they have a serious issue, then they are brought in for a teleconsultation. They are registered. Other cases are referred to the appropriate agencies that they can go to. So when we started off with ISDN line telephones, because that's what was available in 2004. We tried video phones, then we tried computer-based networks. Now things are a little different. So what we have on the left is our central hub in Chennai that we connect up to 5 days a week to the other units. And on the right we have what's the picture inside a mobile unit where we provide our teleconsultations. Again, with rural India, one of the things that we've always seen is having a consultation by itself is quite pointless unless you have treatment that follows it. So you need to have medications available. Psychiatric medications are not that easily available in these remote villages that we're looking at, and if they are available, again, they are not really affordable to the patients. So it becomes, we are bound to make sure that there is medicines available in the same area. So all our buses, or wherever we have our peripheral units, we also have a built-in pharmacy where medication is given free of cost. So our entire services that we provide in terms of consultation, medication, follow-up services, all of these are free. Yeah, so this is just some figures just to show what's been happening. As you can see, our figures are not really that huge, but if you actually look at it for each year, it means if we have seen 223 patients, it means that it's into 12 per year for the number of consultations. So, so basically, so we look at it, we've done something like 12,000 consultations, but we are bound by the fact that we need to look at these patients again and again. So at the earlier stages, probably we need to see these patients every 2 weeks, and it probably goes into a 1-month cycle after that. So this is just a basic distribution of demographics and data we're looking at. Yeah, this is the type of patients that we generally see. Just to break up on the type of illnesses that we have. So as we said, we are focusing on serious mental disorders. So almost 75% of our caseload is on psychotic disorders. Again, we have just looked at outcomes in terms of one of our sites, and we have basically seen that about 70% of our patients have improved, 20% have maintained status quo, and 10% have actually worsened, because one of the problems with psychiatry again is, unlike other disorders, patients often lack insight into the illness, and two, therefore because of that, they will not come for treatment, or if they come for treatment, they don't want to take medication. So this becomes a lot more difficult. The need to involve the families, need to ensure compliance of medications are there in all fields of medicine, but here it becomes especially difficult for you to manage. And one of the things that we've seen as a good outcome is in terms of what has happened when we first started the clinic. We had a range in which patients who came to us have been untreated for 10 years, people who have been untreated for 5 years and stuff like that. So we just tried to see what happens after our service became available. As you can see, in the period of about 4 years, the duration of untreated illness actually fell, showing that people, once the service is available and people are aware of it, they start accessing it and people start coming to you earlier. And this is just little bit of the status and current status that we have and what we are doing. One of the things we are reasonably happy was that our dropout rate is only 19%. Normally with psychiatry it tends to be a lot higher than that. We have been able to kind of leverage the use of mobile telephone, because what we are seeing is 70% of our patients have telephones or their families have phones. So what we have done is some things are quite simple. We call them up before the next visit is due and remind them. With some patients, what we have done, our families, what we have done is we just program that to your basic phone as a reminder, so that they know that it is there. For medications, again, sometimes we just set up alarms on their phone. We are programmed into their phones on alarms. You have to take medicines 3 times a day. There's no way to look at it. We just put it into their phone so that it drinks 3 times a day. So medication is good. So some of these things, that strategies that we have tried, have been useful, and we have been able to see that there's a better compliance to treatment and there's better follow-up rates that's happening. And so basically what we wanted to see is we kind of see very clearly that telemedicine is something that, telepsychiatry is something that can be scaled up very easily. Our experience with it has been very positive, but for some reason it's really not taken off the way it should have in general terms, because like I said, the dependence on gadgetry in telepsychiatry is very little. The investments that are required are quite minimal, but it still hasn't quite gone the way it should have. And just some of the challenges that we are facing at present is in terms of monitoring, because some drugs can have side effects. How do we keep track of it? How do we make them come to us regularly? We have people visiting their homes and stuff like that, but we would like to do a better job of that. The other thing is, the whole of thing is happening through video conferencing. And the question has been raised, you don't even touch the patient once, you don't do a physical examination, how do you do your prescriptions? We have found some ways around it, in the sense that we do send these patients for physical examinations to the judge, the local GP or the closest person that is available. But sometimes the patients are not willing to do that, or the families are not willing to take them. So do you deny them treatment just because they are unwilling to do that? That doesn't seem fair. Of course, we know there are technologies that we can use to probably fill this gap, but then it means added cost. So one of the other aspects that actually needs to be looked at is, some of the challenges primarily is, how do you keep this program going? How do you sustain it? Because it's not cheap doing this. It's probably cheap for the families and the patients, but from the service provider's point of view, how do you make the service sustainable is one of the challenges that you're looking at. Of course, other things are in terms of liabilities and legal issues. What happens, is an electronic prescription good enough? What happens when you shoot from this end? And some key problems that we have had is in sense of, let's say in India, for example, mental illness has grown for divorce. So if somebody comes and gets a e-prescription from us saying something, the wife has not come or something like that, and if this gets used in a court, what happens? How do you safeguard against this? So it becomes an issue of privacy and confidentiality as well. So these are, I think, our messages. So I just stopped with that, and I hope I'm in time.
You crossed it, but anyway.
Yes.
Important speech. Yeah. So I could take one question, just one. Yeah.
You mentioned that in psychiatry you need to see the patient also, expression as well as patient words. So you need to have a very good video conferencing system.
So what we are using at the moment is a static IP, so which gives us, we are using the 2 Mbps line, which gives us fairly good resolution, and we have a system where we can zoom in on the patient if we want. We can just look at the eye if we want and stuff like that.
What is the cost of this type of system?
We are using something which is made by Sony, so it's about, the equipment is about 2.5 lakhs.
Both the
at
ends?
At one end.
Means both the ends 5 lakh?
Both ends would be 5 lakhs. That's excluding your interconnected charges. And
You don't get any cameras less than 2 lakhs.
2 lakhs.
So,
What is the most common diagnosis in your?
That's what I said. We have been trying to focus on serious mental disorders, because that is something that can be managed more with medication. Certain other types of mental disorders would require other types of, you would need psychotherapy, you need behavior modification, you need a lot of other things. which we find don't work that well through telemedicine. You need to spend. So we have tried to exclude those things because
Mainly
there's only so much time and there are so many patients. So we thought we'll focus on areas where we can actually be useful. Then do something for the other people and not be useful for anybody.
Thank you. Thank you very much. The work done by staff is something extraordinary, and they've been doing extraordinary work by doing a lot of free services. So it's a very difficult task for them unless the government comes forward to support them. Telepsychiatry is something, even in the US, it's the most wanted area for telemedicine. In fact, the recent thing is that a lot of people from US are expecting getting opinion from India because you don't get the psychiatrist to come and give opinion so easily. And to see them, it takes about 6 months in the US. So in fact, most of these consultations are going on from India. Thank you very much.